Good afternoon. We have with us Dr. Parshutamal Gautam, an intensivist and HOD, critical care medicine with a background in anesthesia from Tertiary Care Hospital in Ludhiana. We welcome you, Doctor, to the Natco Pharma Specialty Criticon Studio. We look forward to listening to you with advice or to the younger generation of doctors. Those are in the space of critical care management and also those that are associated with bacterial resistance. What, as for you, are the changes that you have foreseen in critical care?
Yes, if I look at my ICU, the most of the patients are coming with the multiple drug resistance. This resistance in the antibiotic, the current data, especially if we see look at carbapenems, it's almost the resistance is going to the extent that whatsoever the guidelines are there that we start with the first line in ICU. Whenever there is a carbapenem is producing bugs, we are finding later on in the cultures that it is becoming resistant. So there, on this aspect, I'll take the two things together. One is the preventive, other is the therapeutic, because we always are concerned about the patients. So if you are using something like carbapenesis, finding like PAFR or multi-PCR, then we can diagnose what sort of the genes are there. So we can design our antibiotic strategy accordingly. So like if patient is a carbon producing, if patient is NDM or non-NDM, we can think of if like a common is Acinetobacter, Klebsiella and E. coli or Pseudomonas. Klebsiella is very common, but produces OXA48. But in India, it's around about 50+% patient having NDM also. So in those patients, otherwise ceftaroline avibactam combination is very good. Meropenem or anything carbapenem is not going to work. So, but if NDM is so high, if isolation in that NDM is not there, then we can use single drug ceftaroline avibactam. But if it is there, we have to use aztreonam along with it. But very important is most of the staff nurses, what they do is make 8-hourly alternative like that. So we should take care of that. It should go simultaneous in the infusion, the full dose. That's the crux in tackling these, handling these patients. But judicious use of antibiotics is the most important. We should have a restricted antibiotic policy in our ICU.
Thank you so much. What would be your main message to the ICU young doctors to enhance patient care?
See, because ICU is most times what we say is, what I teach my students is, there are 2-3 ghosts looking around the ICU. That's why the mortality is very high. One is the errors which are very common in ICU, whether it's a drug or it's a practices, hygiene and other things, or iatrogenic complications sometimes associated with the ventilator or the care. That's one part. Second is the infections. They are always ready to get into the patient because patients are immunocompromised, most of the ICU patients. They are on invasive lines, they are on feedings, TPN, surgical. I mean, their resistance is almost gone. Even if the viral infection is there for a couple of months, so 6 to 8 weeks, their uh, resistance is not good enough. So these patients are very prone to infections. So to avoid these, another thing is the pulmonary embolism, also very common in ICU if we are not giving the DVT flex or making the patient embolization. So these goes to prevent these goes to enter to your ICU. I would say infection is that we should take care of, looking at the infectious practices, that hand hygiene and procedural taking care with the full precautions, uh, washing hands in between the patient. So that's very important. Second, as far as thromboembolism is concerned, patient should be on prophylaxis and as early as possible to take care. Another thing is the delirium and all these things. So humanizing the care in the current scenario is very important.
Thank you so much. That's a load of advice to the young doctors. And I want to now understand with the final question, what is the prevalence of carbapenems in your practice? What are the treatment options? You did bring it up a little.
See, whether it's my hospital or it's the national, the data is there. 2019, I think that the carpenter agency is going to 70% plus or so in ICU. Maybe wards, it's okay, 40-50%. But in ICU, once the patients are there in a couple of days, most of the patients are resistant to carbapenems. 70 to 80% some of the hospitals are reporting, and we are one of them only. because I had to number of places look at the data. Most of the people share the same sort of picture.
Great. We thank you so much, Dr. Gautam, for being a part of the studio today and for sharing your insights on the healthcare management.
Thank you very much.